I would like to wrap up a little bit the whole symposium. Chronic pain, all the same. So there's a question mark behind all the same, so you can think whether you, after all these talks, think it's all the same. So what I think Tony has told you is that impaired descending inhibition and central sensitization are important elements in many, many chronic pain states, and in particular in OA pain and low back pain. And we can restore the descending inhibition and also central sensitization if we use tapentadol. I think these are very, very nice data. So Lars told us that sensitization processes are very important in OA, in particular groups of OA patients, and if we treat them, we have to know about these central sensitization processes. So I wanted to convince you that low back pain is frequent in that neuropathic elements are frequent in low back pain, and that they really impact the quality of life of our patients, and therefore we have to detect them and to treat them adequately. So Andrew, I think this is really important to know. So responders at 12 weeks are also responders at 6 weeks, and therefore we can identify a stopping rule. If there's no response at 6 weeks, we can stop to treat. Is that correct, if I summarize this? Well, and then we saw the results of the head-to-head trial of tapentadol versus oxycodone naloxone, and I've shown you that tapentadol is in many, many items of these trials superior to the fixed combination of oxycodone and naloxone. And with this, I would like to start the discussion, and I have to ask, where's going to start? Tony, I think.
Right. Well, I have several questions, but I think in terms of time, I'll answer two now. The first one says simply, does tapentadol reverse central sensitization? The answer is in the preclinical models, we can directly monitor abnormal neuronal firing, and I can categorically say that in normal conditions, in animals with models of osteoarthritis, that systemic tapentadol does reverse central sensitization in a very clear-cut manner. The other question actually is a very intriguing one. It says, reversal of the loss of condition pain modulation. So one pain against another, that ability to endogenously inhibit pain is lost in animals and in patients in these persistent pain states. The claim has been that tapentadol brings back condition pain modulation, and that descending inhibition now reduces pain. But the question says, could it be the other way around? Could it just reduce pain, and that then brings the condition pain modulation back? And it's a kind of interesting question. It's the former that's the case, because again, in the preclinical studies, we can measure the neuronal activity in these systems, and we can categorically say that simply decreasing neuronal firing, i.e. reducing pain, doesn't restore condition pain modulation. You have to have the right pharmacology. So so the data from animals and humans with tapentadol says the drug brings back descending inhibition, and the consequence of that is now a reduction in pain. It's that way round. And I'll stop there.
Okay, so Andrew, what about you?
Well, again, I've got three questions, but they're all about stopping rules. So maybe I can put them together. I mean, one question here is, why did we choose 6 weeks? We chose 6 weeks for a number of different reasons, actually. And let me just say that's not final, but partly it's because what we've got is cohort studies with a 5-week titration and randomized controlled trials with a 3-week titration, and it seemed fair to leave it to the end of a titration period so that one's got a fair test of the drug. And also, to some extent, because I'm highly influenced by all of my clinical colleagues who've been telling me over the years that one has to give patients a fair trial of drugs, because the effects might take a while to get into action, but also over a period of time the adverse events wane, so you can titrate doses up and down. So that's the main reason for looking at this particular time. Could we have done it earlier? Yes, we could, and indeed we will be looking at earlier results as well when we do more analyses on it. Would the titration be shorter or longer with amitriptyline? No idea, no data. But with duloxetine, the titration would be about the same period of time. There's an individual patient data analysis with duloxetine. And in painful diabetic neuropathy, but not in other conditions, it would seem that 6 weeks would be a sensible time. You might be able to get away with earlier times with duloxetine in other conditions. Paracetamol, well, paracetamol doesn't work in chronic pain, so I don't see that that's a relevant question. But for NSAIDs, it certainly does appear that one can titrate over 2 weeks, and if you're not getting a result by 2 weeks, you're probably not going to get a result ever.
Okay, I think I will continue with some questions. One is a very nice one. It says, there's no good anatomical evidence for nerve sprouting after peripheral nerve injury, so please revise your presentation. This is nice. So, well, what I wanted to say is not that there's sprouting after a peripheral nerve lesion. I wanted to show that you see and can demonstrate the sprouting into the disc after a degeneration of the disc. So first there are blood vessels growing into the disc, and these are followed by tiny nerve fibers. So this doesn't have anything to do with the peripheral nerve lesion, so perhaps I do not have to revise my presentation. So the other point, some of the questions are around how assessing neuropathic elements in the back, and which tools can we use for doing so, because as you know, quantitative sensory testing takes a long time, as the equipment is expensive and so forth. So we are just analyzing the data from our research work to identify the most important elements of pain detect, and also bedside examinations to distinguish neuropathic back pain due to the dorsal ramus from the axial nociceptive type of back pain. And Maren Reimer from my group just showed some results of this during the workshop yesterday, I think. So there will be some results from this soon. Another question says, why is spreading of pain mostly more distal but not proximal? So I think if we talk about projected pain due to a root lesion, it's true that we have the first changes and pain is in the distal regions in the foot. I think this is due to the length-dependent problem, and the long fibers which project to the foot are suffering from problems first. But if it comes to referred types of pain, which is a nociceptive type of pain, these are really more frequently located in proximal area of the leg. So this depends on the site of the lesion. And with this, I would like to hand over to Lars.
Thank you. We're trying to get all the cards ready here. There are several questions here addressing aspects related to surgery, and aspects related to either treatment before surgery or what is happening if the surgery is actually removing the pain. Will that have an impact on the central consequences? It's quite evident that if you have, for example, as we've been discussing today, knee or hip osteoarthritis, you go through a successful surgical procedure having joint replacement, and at the end of the surgery, after let's say several months later, the pain has gone, the central consequences are actually normalized. There has been a kind of a notion that some of these central manifestations will kind of remain, but when we look at it and we assess it, the system is actually kind of restored. So it seems that for musculoskeletal pain condition, we are coming back to a normal system if the surgery is eventually solving the problem with the pain. But in those patients where the pain is not gone after surgery, we know, for example, for knee replacements, 15, 17, 18% of the patients, they will still continue to have pain after surgery. And if we look at those patients 6 months or 12 months after surgery, where they still have continuous pain, these central consequences are not reset. They are still impaired descending control, they are still facilitated central integration. So it's very evident that if you actually remove from musculoskeletal conditions, if you actually remove the sensory input or the pain input, you will actually restore and reset the sensitization processes. So the next question is then, can anything be done prior to surgery in order to try to dampen down the system before surgery, and will that have an impact on the outcome, for example, for tapentadol or duloxetine. I mean, at this stage, there are no real studies showing the effect on chronic postoperative pain. There's only, as I'm aware of, only one study showing that if you give pregabalin prior to surgery, there are some indications that that will minimize the development of chronic postoperative pain after knee replacement, but there are very little evidence. But I think if you have a group of patients with massive impairment of the descending control, massive facilitation of the central integration, those patients are definitely in a kind of a risk group in order to develop more chronic postoperative pain. But within that area, we need far more data.
Well, I think we could start another round. We have 3 more minutes left.
Right.
What about you, Tony?
Again? Yes, again, two excellent questions, somewhat detailed. So one of them, why doesn't tapentadol have an antidepressant effect? It's a very interesting question. There may well be effects on mood and anxiety as a consequence of reducing pain, but it could well be that for an antidepressant effect, drugs such as the tricyclics, the SNRIs, might need a serotonergic mechanism, since SSRIs can be useful on mood. It's probably also related to the fact that the way noradrenaline is regulated in pain appears to be different from the way it regulates itself in mood. And then a question about the actual opioid load of tapentadol versus oxycodone. And again, the person who posed the question made a very good point. It probably relates to comparison of the side effect profile. So if you look at the GI tract effects, and they're half with tapentadol compared to oxycodone, maybe the opioid load is half, but we don't know what's happening at receptors in real life. And less nausea and vomiting compared to tramadol. Well, 5-HT is facilitatory in pain. It is the source of descending excitations. It also facilitates at the chemoreceptor trigger zone. And so not having a serotonergic mechanism in tapentadol may also aid reducing nausea and vomiting independently of the opioid effects. And terribly briefly, a very nice question saying, how can we communicate the cause of pain to our patients, the suggestion, disturbed nervous system? I mean, I have given my kind of conclusion slide to many healthcare professionals, predominantly nurses, who just sit down with the patient and say, your periphery is not too bad, your spinal cord, your accelerators have gone wrong, and the brakes in your central nervous system are failing. We can't see them, but that's what's going on, and that's why your pain is abnormal, and maybe pharmacologically we can fix it. So I think simple analogies can help patients and, in a sense, gives them confidence in the treatments that are being proposed.
Well, do you have some left? No. So I have a question here which asks whether we have experience in chemotherapy-induced neuropathy with tapentadol. And in fact, there are no studies and trials having tested this, but because chemotherapy-induced neuropathy is very likely a mixed pain syndrome with neuropathic and nociceptive elements, I think it's a good idea to try, and we in fact did try with a good response of the drug. So you could do this. And then finally, it says, is there a chronic pain without a neuropathic component? And this is a very good question, I think. And you know, I'm a neurologist, and neurologists see nerves everywhere, yes. And there are nerves everywhere. But perhaps I have a bias there. But to my personal view, many chronic pain syndromes have neuropathic elements. And I think with this word, I would like to close the discussion round and would like to thank Grüntal for sponsoring this, in my mind, wonderful workshop. I would like to thank all the panelists here for their talks, and obviously you for coming and for listening and for discussing. Thank you very much indeed.